Assalamu alaikum. This is Dr. Zahra Alhaj Issa. I am an internist, and today our lecture is about approach to management of acute GI bleed. It's another medical emergency, and sometimes it can be life-threatening. So this is our outline as usual: definition and classification, clinical manifestation, initial management, further approach, diagnostic studies, common causes, obscure GI bleed, and then our references. So what's a GI bleed? It's an intraluminal blood loss anywhere from the oropharynx to the anus. It has two types or classification: upper and lower GI bleed, and this depends on this anatomical landmark, which is the ligament of Treitz. So if it's above that, it's an upper GI bleed. If it's below that, it's lower GI bleed. What's a severe GI bleed? That's an important definition. Severe GI bleed means that it requires hospitalization, or in other words, it is having associated shock, associated orthostatic hypotension, or that it decreases hematocrit by 6% or hemoglobin by 2%, or that the patient required transfusion of more than 2 packed RBCs. So manifestation: how will the patient present in ER? The patient might come with hematemesis, which means blood in vomitus, or the patient might have a coffee ground emesis, which means blood exposed to gastric acid, which changed its color to coffee ground. Both these manifestations are of upper GI bleeding. Then the patient might come with melena, which is a black tarry stool from digested blood. Usually it's an upper GI bleed, but sometimes it can be from a right colon bleed. Then hematochezia, which is bloody or maroon colored stool. Usually it's a lower GI bleed, but sometimes could be from a very rapid upper GI bleed that did not allow it to be digested. How will you manage the patient in ER? Any patient coming with GI bleed in ER will require you to assess and assure his stability. Well, how can you do that? You can do that following ABC approach. A means airway, B means breathing, C means circulation. So you make sure that the patient can maintain their airway, otherwise you have to secure it. Then you have to make sure that they have a good breathing and good circulation, otherwise you will correct that on spot. Then you have to assess the severity of GI bleeding, as we mentioned. This will ask you to check the vital signs, including orthostatic changes and their JVB for volume status. So if the patient has tachycardia, which can sometimes be masked by a patient taking a beta blocker, this means that this patient has lost 10% of his blood. If the patient has orthostatic hypotension, means that they lost 20% of their volume. If they present with shock, this means that they have lost 30% of their volume. And from the moment of triage, you have to do the following. You have to alert the endoscopist. You have to alert the GI on call that you have a case of GI bleed, so they can prepare themselves and come to assist the patient as soon as they can. Then sometimes you have to consider or notify the ICU if the patient is really unstable. And then sometimes you have to intubate in ER if the patient has ongoing hematemesis, that it's threatening their airway, or if they have severe shock, or if they have poor respiratory status or changes in their mental status. How will you resuscitate the patients who are having clear signs of volume loss? You have to place 2 large bore IV lines, and you have to start fluid immediately. It can be normal saline, it can be Ringer lactate, any of the isotonic solutions to achieve normal vital signs, normal urine output, and mental status. You have to monitor these three to make sure that your resuscitation is adequate. So your patient is more stable now, and you have chance to ask about history. You'll ask about the prior GI bleeding. How was it? When was it? How was it managed? How about their current bleeding? How strong was it? And then do they have, for example, melena with their coffee ground vomiting or any other manifestation? Because often they are combined. And then if they have any other GI signs or symptoms like abdominal pain, changes in bowel habits, weight loss, nausea or vomiting, and then if they have any medication that makes them at risk of GI bleed, like non-steroidals, aspirin, or any other anticoagulant or antiplatelet, if they are alcohol users, if they have any liver disease, if they underwent any radiation, or if they underwent any surgery, especially GI or aortic surgery. So all of these points are very important and they might guide your diagnosis. Then if you go to the physical exam, other than the things that we said we will assess initially, you have now to look for any localizable abdominal tenderness, any peritoneal signs, any masses, any lymph nodes, any prior surgery scars, any sign of liver disease, and you have to do a rectal exam. Unless the patient refuse, or if they have severe anal pain that might point to, for example, anal fissure, then you cannot do a rectal exam. But if they agree, because it might give you the diagnosis, they might have hemorrhoids, you might find masses, or sometimes you might see the melena they did not tell you about. So when you do a BI, or if you see the stool, you should check the color, the appearance, and you should send it for occult blood. So what labs are important in GI bleeding? CBC will give you more than one clue. For example, the hematocrit, if it's decreased by 2 to 3%, it shows you that they lost approximately 500 ml. You should know that it might be normal in the first 24 hours of the GI bleed before it equilibrates. Then another clue in the CBC is a low MCV. This means that this blood loss has been going on for a long time, and it made the patient iron deficient. Another important investigation is the platelet in the CBC, and then the coagulation profile. Also, you should check their renal function, because they might have a perirenal isothemia because of the volume loss, or even they might have urea to creatinine ratio increase, which is because of GI absorption of the blood. Then you have to check the liver function, which might show you that they have liver disease. Then how about transfusion? Should we just give blood to anyone, or is there a specific indication? Well, initially for any patient you should just send blood sample for cross and match stat, and then you have to transfuse if the hemoglobin is less than 7 or less than 8 if the patient has a coronary artery disease. So this is a more restrictive approach, and this showed a better mortality in the trials. That's why it's now in the guidelines. If you don't have time for a cross and match and they're profusely bleeding, you can use O negative. Then you have to reverse coagulopathy, of course. If they have, for example, a high INR, high prothrombin time, you have to give fresh plasma and vitamin K. If they have thrombocytopenia, you have to give platelets for a minimum of 50,000. Then, okay, you assess the severity, you sent some labs, you took the history and physical exam. Do you have to admit all the patients? Well, some patients qualify for outpatient management. Who are these patients? They are the ones who have all of these conditions. First, their systolic blood pressure is more than 110. Their heart rate is less than 100, so no tachycardia. Their hemoglobin is not decreased, so 13 or 12 depending on their gender. Their urea is normal. They have no melena at this time, and no syncope, no history of heart failure or liver disease. This is actually taken from Glasgow-Blatchford score. So these patients who qualify for outpatient management should have a score of 0 to 1. And this is also based on the American College of Gastroenterology guidelines.